Dr. Page-Phillips, we're going to turn it over to you, and thanks so much for being here.
Of course, it's my pleasure. I can also turn my camera off too, because I'll have to be sharing my screen if that's a little easier. And can everyone hear me okay? You can just thumbs up me or.
Yep, we can hear you.
Perfect. Yes. Okay. Share my screen, hopefully. And can everybody see this PowerPoint?
Yes.
Yes.
Excellent. Okay, so we'll get started. So I just kind of loosely themed this navigating COVID as our topic today. And as was stated, I am Ebony Page-Phillips. So kind of the overview of what we'll talk about, just a brief introduction. We'll talk about the burden of disease, the burden of COVID, kind of what the numbers are looking like, some frequently asked questions and questions that I received, some evidence-based medicine, kind of what that is and how that impacts our treatment plans, the COVID vaccine, the pandemic within a pandemic, my experiences, and then just a few closing thoughts. And again, interactive, if you have questions, please put them in the chat. I have Havana already assigned to looking those up and letting me know and keep me aware of any questions that may come up during the presentation or clarifications. So a little bit about me. I'm Ebony Page-Phillips. I am an emergency medicine first-year resident. I am not an infectious disease expert, although I have been able to see and learn a lot from our infectious disease experts here at MU and just kind of globally. I have a lot of what I've learned and what I'll kind of touch on today are things that have come out of the research that I've done, the research that a lot of people that are much smarter than me have done. And it's kind of a compilation of my experiences with that information as well. I'm from St. Louis, born and raised, just left to go to undergrad. So I'm happy again to be doing this for this coalition that is especially looking out for those victims of violence in the Missouri area. I do not have any disclosures, and I want to say thank you to you all for inviting me to speak. As a baby doctor, it means a lot that you guys, want to hear what you have to say as a medical profession, but also as just someone that is getting out and wanting to be better at communicating health information to audiences even outside of the health field. So the burden of disease, what is it looking like? So what is coronavirus? Severe acute respiratory syndrome coronavirus is one of 7 coronaviruses known to infect humans. Most of us have been exposed to a strand of coronavirus. It typically causes the common cold, so we don't really think much about it. However, we have this pandemic based on a strand that is just more virulent than previous strands. Globally, over 200 million confirmed cases of COVID-19 have been reported, and this is why it is a pandemic, meaning that it's expanding beyond just one community, one population. It is continents, other continents outside of just one have been impacted. In the US, there have been 47.2 million who contracted COVID, 764,427 killed since January. And in Missouri, I got these updated numbers actually from the tracking COVID cases on CNN, updated today. And as of this morning, there were 879,624 cases in the state of Missouri. And they look at it per 100,000 people. And so that's about 14,000 per 100,000. And then death rate, 12,900 deaths, or 210 deaths per 100,000 people. And to some, that doesn't, seem quite as striking when you think about it as a percentage. However, if you're just looking at the sheer amount of people who have died, I think that's, it's terrible. That's a huge burden of disease because in some of these cases, they were preventable. So overall in Missouri, cases as of, again, today have been rising. We're at a 41% increase kind of from what our baseline had been previously. Here on the CNN website, again, you can actually click by county, and you can see for the day and for the county how many cases, how many deaths, and all that information is there. You can click the link that'll go out on this PowerPoint and kind of look at your own counties to kind of see what is the burden of disease in your specific region, in your specific area. And again, some of this is thought to be a underestimation due to the differences in diagnoses and reports. So keep those numbers in mind, but know that they're likely a gross underestimation. So some frequently asked questions. What is the risk of contracting COVID in the community? Since we have, these cases that we just talked about, how can we quantify that as far as risk goes? And so again, there's plenty of these calculators out. This is a great one that we use. It's by Georgia Tech. They came out with this kind of risk assessment calculator where you can put in, if you're having some type of gathering, how many people, and you can use your particular regional numbers to kind of get an estimate of what the risk is in the community. So here on the x-axis, you have the number of people at said event, and then on the y-axis, you have the number of cases in Missouri just that are circulating. And like we talked about, we have about 132,000 cases right now in Missouri. So for a dinner party of 10 people, if you kind of track, we can use 121 because that's what it was, I think, when I pulled this graph. But there's about a 18.19% chance of contracting COVID in the community with a 10-person dinner party. Then with 100 people, let's say a wedding reception, you kind of go over, and then there's an even more greater chance of contracting it. And you go, obviously the more people, the more individuals in the community with the virus. So you can see how this pandemic is kind of continually escalating, and why cases are rising, because we're opening up more venues, and we're having concerts, and we're getting back to the things that we love, which is great. But at the same time, we're increasing our risks of contracting the disease. So the main way that this virus is spread is through person-to-person respiratory particles when you're in close contact with others. Typically, the virus is transmitted prior to the development of symptoms, and it's usually easily transmissible the earlier in the course of the illness that someone comes in contact with you. Closeness and duration are going to increase the infection, which that makes sense. And then these super spreading events are thought to be major drivers of the pandemic. And basically, these are events where there's a close proximity of individuals that are coming from different places. For instance, a wedding, geographically different places, they're exposed to the virus, and then they in turn take the virus that they've acquired at the said event, and they go back to their places, their communities of origin, and then they spread what was initially kind of contained at the wedding or whatever event, and that is a super spreading event. And imagine having multiple of those events in different areas, how fast we've seen these numbers go. So notes here. So yeah, major drivers of the pandemic: prolonged exposure, usually indoor spaces. We've seen plenty of examples in the news of this. So again, how does it spread? Mainly from close contact with infected persons, when they talk, when they breathe, when they cough. So that's why the mandate has been stay 6 feet away from others, wear a mask. People are contagious when they are sick and 2 days before they show symptoms. So this is why it's important to stay home and isolate if you are sick or if you're starting to feel sick. Respiratory droplets can land on surfaces. The virus can live for hours. We don't think that the virus is easily spread that way. However, out of an abundance of caution, still we recommend cleaning surfaces and hands often. Smaller respiratory droplets are aerosols. They linger before they fall to the ground. So keeping kind of ventilation open. That's why a lot of events have moved to outdoor spaces, because there's a less chance of kind of the virus kind of lingering in the air. Again, spreads easily when there are more people indoors for a longer amount of time, poor airflow, so avoiding crowds, keeping trips short, and wearing masks.
Hey, Dr. Page-Phillips, we just had a question from the chat I wanted to ask before we got too far ahead, but it's from Beatrice, and she said she loves the colorful chart. I agree, it was beautiful. But also she wanted to know from the stats given, are they taken into account with people wearing masks at events or without wearing masks?
This is stats based on just a general risk of maskless kind of people in proximity to one another. So talking a little bit more about masks and the kind of the importance of them, just to kind of give a visual of what these droplets in size are. So here we have kind of a strand of hair is 15 to 180 microns in diameter. And we're looking at kind of what mask can filter out. So you have your surgical mask, which is typically what most people are wearing. They can filter out anywhere from 2 to 10 microns. And then your N95 is going to be, important more so for healthcare professionals, because they're going to filter out a little bit more. And so you have max exposure here when you have an individual with the virus and they're unmasked completely. They're going to be most at risk, obviously. And then the least amount of exposure is going to be when you have 2 masked individuals, because you're kind of blocking it from both ways. A lot of times people think that like wearing a mask is, protecting them from the virus. And usually it's more so that you're protecting others if you're thought to be infected. That's why a lot of places were saying, like, if you weren't vaccinated, that you should wear a mask, because it was likely that you would be the kind of spreader of, things. However, as we can see, when at least one person has a mask on, you're going to minimize your exposure. But when both people do, the chances of spread are even less. So back to kind of surface things. These are just kind of estimated how long things kind of remain on surfaces. And this is just kind of for reference. Again, we don't think that this is a major way of spreading, but just when you're working in environments where, you're touching a lot of things and you're providing services to people, knowing that if you're having water bottles at your events, it can linger on plastic for up to 3 days. If you're having, paper or different, surfaces that are going to be touched by multiple people, it's important to make sure we're cleaning and disinfecting those. The most effective thing is like alcohol-based, at least 60% of ethanol. Your typical, Lysol and over-the-counter things like that work fine as well. Soap and water, bleach, just all that kind of, standard practice applies here as well. So when we talk about the symptoms of, COVID and what they are, sometimes people don't show any symptoms, and these are the asymptomatic people that are kind of like the feared carriers of COVID. Other symptoms can be severe, and for some they can be fatal. The part that as a medical professional we have to be honest about is we don't know how someone will respond to the virus. There are risk factors that I'll talk about, but our body's immune system and the way that we respond to foreign infections or any allergen are going to differ based on that person's exposure in the past, based on the environment they're in typically, and just their natural body's immune system in responding to that. And what we've seen is that some people just get fever, runny nose, cough, and then you have those that kind of progress with shortness of breath and pneumonia, which is likely due to what we think are inflammatory mediators that are basically trying to fight off this virus, but they kind of go haywire, and that their response to the virus is more severe than what it needs to be. And so it ends up damaging healthy tissue and leading to just damage in the lungs. GI symptoms are very common. A lot of times people will come in and they'll just be having nausea and diarrhea. Kidney failure, again, the body's way of it just kind of shutting down when it has an infection to try to protect itself. And we don't know how individuals will respond, but these are some of the kind of main ways. Children who are, 2 years old and younger, those who are 65 and older, they don't have strong immune systems. They haven't had, a lot of exposure to some of the more virulent pathogens, or as you age, your immune system kind of declines with time. So these are people that are particularly susceptible to the more severe complications. And so when we talk about incubation period, what is that? So on day one, if you're exposed to the virus, most people will develop symptoms usually around day 5 or 6. And so the incubation is simply the time between when you were exposed and when your symptom onset began. And so the incubation period for COVID has thought to be between 2 and 14 days. That is typically why if you were exposed to someone with COVID on day 1, you're likely not going to test positive on that day. The virus needs time to replicate. It often takes, like I said, up to 5 days or more to generate enough particles that the swab can identify on a molecular test and diagnose you with that. So we have the rapid test, which typically in the ED, we use those on symptomatic people. So if you're coming in with a fever, runny nose, cough, diarrhea, we'll do the rapid test, and those are generally positive because people have developed symptoms. However, in asymptomatic individuals, oftentimes, if they're coming in with nondescript symptoms, then we might have a concern. We might do a PCR test, which is a test that can take just a little bit of virus and replicate that. And it will typically take a little bit longer, a day or 2 to come back, but that's a more definitive test for positivity. So again, what increases the risk of severe disease? Lots of things. This is kind of like our medical journal Bible, up to date, where different professionals will come on and infectious disease in different areas, and they come together with peer researched evidence to kind of create these articles. And this is a table from one of those articles that talked about different comorbidities that are going to increase the risk for severe COVID. So cancer, any type of cerebrovascular disease, so people that have a history of strokes or aneurysm, children with underlying conditions, particularly I think Down syndrome, or our cystic fibrosis kiddos are at risk because they already have some underlying damage to their lungs. Chronic kidney disease, anyone with lung disease that makes sense, the virus sets up there. If it's already kind of having some injury, you're just adding injury on top of injury. Chronic lung disease, chronic liver disease, diabetes. Again, diabetes is something that causes the immune system to be lower, so you're more susceptible to this virus. Heart conditions, heart failure, HIV, again, no immune system. Mental health disorders, neurologic conditions, obesity, overweight, pregnancy or recent pregnancy, smoking, sickle cell disease or thalassemia, solid organ or blood stem transplant, substance use disorders, tuberculosis, use of corticosteroids or other immunosuppressive medications, and then some other possible risk factors are asthma, hypertension, and other immune deficiencies. Again, we don't have enough information and data to say for sure, but kind of when I think about the patients that we see in the ED that end up on ventilators or on BiPAP, a lot of them fall under this category. And sometimes they have no history of this, but oftentimes if they do have a history, it's something off of this chart here. This is my kiddo. So how does COVID affect children? So the symptoms for children and adults are very similar. It appears to be milder in kids than adults, but we do see severe cases in kids. Boys and girls are affected equally. Most commonly for kids is the fever, chills, and a cough. Usually this results from a household exposure of an unvaccinated adult. I worked in the pediatric inpatient unit for 4 weeks during my intern year this year. And although the majority of the kids had RSV, which is a different virus and it's pretty severe for them, we did have some COVID children that were pretty pretty sick. They were healthy otherwise. And typically, I think all of the kiddos that I saw that contracted it were living with parents that were unvaccinated and had spread to them. And initially, they were coming in for just kind of fatigue and decreased ability to kind of tolerate liquids and solids. And so they were very dehydrated. And it typically took 5 to 7 days for them to kind of recover from this when they had to be hospitalized. Higher rates of vaccination coverage and full vaccination among adolescents were associated with lower rates of hospitalization. Kiddos less than 1 year have been associated with increased risk for severe disease. That makes sense. Again, they don't have much of an immune system to kind of fight off this virus. They've never been exposed to other viruses in the past, so it's just kind of hard for them to mount a response to this one. The CDC COVID-Net provides information about medical conditions in hospitalized children according to age. And the COVID book is a link that I've placed in the PowerPoint. Is basically a resource to help kids understand in their own way what is COVID. If you're having to have these conversations with young kids about, why are we wearing masks in school, and kind of just gives basic information for that they can understand. And then another important piece is just the trauma-informed care from the emotional and psychological impact of COVID. Between March of 2020 and April of 2021, an estimated 1.5 million kids around the world had experienced death of a parent or caregiver, a custodial grandparent or other relative. And so they're experiencing, losses more than usual. And this has been associated with ACEs, or adverse childhood experiences, that can affect the long-term health of these kids and their well-being. So just being mindful of not only the health impacts, but the emotional and psychological impacts. It's important to think about programs that promote safe, stable, and nurturing relationships for these kids. And, our job as health professionals is to kind of screen and make sure that not only these kids are, okay from the health standpoint, but that their emotional health is okay too. The third complication that everyone kind of thinks of when they think of kids contracting this virus is the multi-system inflammatory syndrome, or MISC, in kids. And this is just that chart of hospitalizations from these kiddos and what age ranges were hospitalized. And as you can see, the majority of kids fared off pretty well, but there are still kids that are hospitalized. So back to MISC, it's basically a multi-system inflammatory response. Again, when the body is trying to fight off pathogens, it mounts these different inflammatory responses, and sometimes it's mild and other times it's pretty severe. So a mild case you may not notice, but as it kind of develops into a more severe illness, it's cardiac involvement. So kids may have chest pain, they may feel short of breath, they begin to develop headaches, they're persistently fatigued even after it seems like the virus should be gone. We typically look at organ systems as a way, to tell the severity. So if there are more than one organ system involved, so if kidneys are involved and they're having decreased urine output, that's one system. If they're having chest pain or feeling like their heart's racing, and they may have some type of myocarditis or inflammation of the lining around the heart, that's another kind of system. And so these are things that we look at when we see kids come in, and how we instruct parents as far as kind of looking for the different symptoms that may lead us to thinking that they might have this particular syndrome. And so you get COVID. What does that mean next? So most people with COVID can be safely managed at home. Supportive care is with medications to reduce the fever and to get rid of the pain of like the muscle aches. Typically Tylenol is recommended, hydration, maintaining a close relationship with your primary care physician, someone that knows kind of what your baseline health is, so that they can be able to check your labs and kind of be able to be seen in the office and see if there's anything that's concerning since the development of the symptoms. Obviously, monitoring yourself for clinical worsening, increased shortness of breath. These are things that would prompt someone, should prompt someone to be evaluated in the hospital or urgent care. Separating from other household members, including pets, is kind of important when you think you may be exposed, even if you haven't had a test yet. Because again, we talked about the incubation period of this disease. Frequent hand washing for all family members, disinfecting. Even if symptoms are mild, again, avoid leaving the home or going to work, possibly affecting others in your community. Right now, the recommendation for isolation is to isolation can be discontinued at least 10 days after the first symptom. In addition, you have to be 24 hours without a fever or and have respiratory symptom improvement if you have those symptoms. So 10 days from the initial onset of symptoms, not necessarily when you had a positive test. Like if you took a test 5 days after your symptoms started, you can still count that 10 days when the initial symptoms started, because the virus replication is thought to have been decreased by then. And then having no fever for 24 hours and improvement in your respiratory symptoms. So what about a household member? Same thing applies. You want to isolate the sick person, keeping them at a distance, keeping the rooms ventilated. You want to take care of them, of course. If you're going to be in contact with them, obviously, wearing a mask, continually focusing on hand hygiene, washing surfaces, separating dishes and cups, and just kind of doing everything that you can to mitigate that risk. Danger signs, difficulty breathing, confusion, loss of speech or mobility, chest pain. These are some reasons to go to the emergency room, call 911. What we found about COVID is that it does increase the risk of your coagulation or your blood clotting. And so a lot of the symptoms are getting at people that are at risk for having strokes and heart attacks, because this virus, again, causes your body to respond in a number of different ways. And one of those ways is for us to increase our clotting factor to try to get rid of that virus the best way our body knows how to. But this can lead to adverse outcomes, and particularly in those with those comorbidities that we talked about. So now we'll talk a little bit about vaccine hesitancy. The first thing, I think it's important to recognize the historical and current systemic structural racism, ableism, and other forms of oppression that have made it difficult for some communities to trust the medical, public health, and scientific community. There are numerous cases and historical reasons as to why people are hesitant, and I think it's very reasonable to have questions and to have concerns about this. Understanding the risk to self and community, how do our personal decisions impact those around us? So with vaccines, this is one of those things that affects more than us. We'll talk about herd immunity soon after this, but understanding with vaccines and different things that affect the community, oftentimes we have to consider how our personal decisions impact those around us. And there are a lot of things that we can do to ourselves and avoid for our own personal reasons, but we have to understand that oftentimes that impacts the most vulnerable people in our populations: children, elderly, immune compromised individuals who don't have the choice. Evidence-based research, we'll talk about how you can combat hesitancy with research and with evidence, and with the best evidence that we have at the time to make those decisions. And other considerations: what's worse, the potential side effects of a treatment versus the potential complications of the disease. I talked about how COVID makes you hypercoagulable. There was a lot of concern about the Johnson & Johnson vaccine causing blood clots. And we'll have another slide about that as well, about the safety of that. And so people were really nervous about the vaccine in general after that came out. But if you look at numbers comparing the amount of blood clots that individuals got when they had COVID from when they had gotten the Johnson & Johnson vaccine, there was an exponential increase in coagulability from the virus itself versus the vaccine. So again, a lot of the things, the myocarditis are inflammation of the heart muscle that people were saying, was a complication of the vaccine. And some people, it's way worse if you actually get the virus. So I think you kind of have to weigh those kind of potential side effects. And then in the event that COVID is contracted, which we saw a lot of people that got COVID, the current treatment is more experimental than the actual vaccine. We have all these new monoclonal antibodies that are recently developed and have gotten emergency use authorization that are not approved just yet, that we typically treat those people that have severe COVID with, that are not as well researched as the vaccine itself. And a lot of what we've been seeing is individuals that come in with severe COVID and, due to vaccine hesitancy or not wanting it at all, but they do want the experimental treatment that is used to try to, ease those symptoms and keep them from mortality, as well as intubation and different things like that. But again, these are things to consider. And then with everything, there's always a risk, there's always some benefit, and there should always be alternatives. And so that's something that when you talk to your healthcare professionals or your family or your clients, always, give people the option with information, especially with information regarding the risk and benefits and what other options they have. So we'll talk about herd immunity. What is herd immunity? Herd immunity occurs when a large population of a community or the herd becomes immune to a disease. This makes the spread of disease from person to person unlikely. As a result, the entire community becomes protected, not just those who are immune. Uh-oh, I'm doing annotations or something. Unlike the natural infection method, vaccines create immunity without causing illness or resulting complications. So it is possible to achieve herd immunity from natural infection. However, depending on what the infection is and how severe it is, it may wipe out part of your population because the actual infection is so dangerous. In addition, there's no, particularly for COVID, we don't know exactly how long natural immunity lasts. However, with vaccines, there's typically an availability to get boosters and kind of increase the antibodies and without the risk of those complications. Using the concept of herd immunity, vaccines have successfully controlled contagious diseases such as smallpox, polio, diphtheria, rubella, and many others. And we're actually seeing a resurgence of some of these in our pediatric populations due to more vaccine hesitancy than before. A lot of individuals that were immunized themselves as children and have family that are now, for various reasons, a lot of which are just kind of misinformation on social media or talking to people that are not medical professionals, have decided that they don't want their children to be vaccinated for the different reasons. And so what we're seeing is that our herd is becoming less immune to these diseases, and it's spreading to those children that are immunized, but more so it's affecting the children themselves that are not immunized because they no longer have that vaccine as a cheat code to kind of give them some information about how to fight off these viruses and that we've had in the past. So a little example of this. So this is a herd where you have people, no one is immunized. And as you can see, the contagious disease spreads throughout the population. Those individuals in red are the ones that are kind of spreading to the unimmunized people that were initially healthy. So when some of the population gets immunized, you have some spread in the population. But as you can see, you're getting some healthy people in there to kind of block transmission to some of the others. And then when most of the population gets immunized, you see that the spread of the contagious disease is contained. Unfortunately for COVID right now, we are not sure how many people we need to have vaccinated to get herd immunity, because there are different variants and there are different communities with different rates of transmission. And so that's making it a little bit difficult to calculate that number of how many people, but we just know that if the majority of the population in general gets vaccinated, then you have that protection. So now we're going to talk about evidence-based medicine. So evidence-based medicine is essentially the aim that healthcare professionals should make conscientious, explicit, and judicious use of current best medical evidence in everyday practice. This comes from reviews of medical literature to evaluate the best evidence, from synthesizing clinical topics, and then translating this into practice for treatment. So treatment recommendations should always be based on the best current evidence available. So how do you look at a medical study? I know a lot of times people are like, do your own research, and you can't trust what's on social media, and you can't trust this and that, but nobody's really given us the tools to kind of do our due diligence ourselves. So this is what kind of we learn in school, as well as a lot of different people practice this method of PICO for looking at things. What is PICO? PICO is P, population. What is the patient population or problem that the research is looking at? I, what is the intervention that is being tested? C, comparison. What is your control group? In order to really look at the comparison between two things, you have to have unaffected problem population and then someone that is trying the treatment or whatever, so that you can see the true differences. And then O, outcome. What is the major outcome of the intervention? Some other things to look at. What is the study aim? Does something work? Is it good or bad? What are the researchers looking at? Confounding factors. What are other factors that can contribute to the results? Oftentimes we can't take things at face value. You have to understand that there may be other factors at play. Who is funding the research? What interests are at play? And who has reviewed the study for validity? Typically in scientific literature, journal editors help to limit bias in trial reporting. It's important to look for things that are peer-reviewed articles. They have different mandates that reports and clinical studies conform to a particular standard. Usually it's the consort or the consolidated standards of reporting trials, which is a set of guidelines that physician investigators use to kind of standardize their trial methods, ensure that consent was obtained by the participants, and that the research and therapeutic regimens are safe and able to be administered to the public. And then after that, you have academic internal review boards. The U.S. Food and Drug Administration has advisory committees, other peer reviewers, and all of these people work together to make sure that the drugs that are supported are unbiased and reach the market and clinics safely. So we're going to use PICO for an example. So this is one of the first articles that came out about the Pfizer vaccine. So the scientific name for the Pfizer vaccine is BNT162b2, but this is just the Pfizer vaccine. This came out in December of 2020. So some things have been updated since this, but I just want to give you an example of kind of how to look through an article. So this is kind of a summary page that you can find most of these articles for free on the New England Journal of Medicine sites. They have peer-reviewed articles, health articles about just about anything. And oftentimes they'll kind of break down what I was talking about, the PICO, the population, the intervention, comparison, and outcome there. But we're going to do this exercise together. So first of all, what is the study aim of this paper? So the study aim, number one, was to determine how effective the Pfizer vaccine is in comparison to not being vaccinated, and two, to determine how safe the vaccine is. Who was the population? So the population was 43,548 people. The initial trial that they had involved individuals that were 16 and older. They were healthy, or they had stable controlled chronic medical conditions. So diabetes, hypertension, that means they were taking their medications. They were stable on those. It was multinational. It was placebo controlled, meaning they had a control group, someone that did not receive the vaccine, instead they received saline, and it was blinded. The importance of a blinded study is that the individuals that are providing the treatment and doing the analysis of the data do not know who is in what study, so that the data cannot be skewed one way or the other. It eliminates bias. And so if you look at the breakdown of demographics, the majority of individuals kind of that participated were white, and then you have some minorities. The male-female distribution was pretty even in the studies. So what was the I, the intervention? So the intervention was randomly assigned persons 16 years of age or older in a 1-to-1 ratio were going to receive 2 doses 21 days apart of either a placebo, which was the saline, or the Pfizer vaccine. What is the comparison? Again, 21,720 people received the vaccine and 21,728 received placebo. So we can see what is the 1-to-1 difference. What was the outcome? So again, the initial question was about efficacy. So there was similar vaccine efficacy, generally 90 to 100% in all subgroups. So this was despite age, sex, race, ethnicity, their baseline like weights, whether or not they had a pre-existing condition. And from that data, among 10 cases of severe COVID, after the first dose, 9 occurred in the placebo and 1 in the Pfizer group. So all in all, we have 8 people who contracted COVID from this sample that received the vaccine, and those that received salt water or no vaccine, 162 of them contracted COVID. So this tells us that the vaccine was 95% effective at decreasing the risk of contracting COVID. And when you think about confounding factors of those, even those 8 individuals that received it, we think about like how many of those people were exposed to the virus before actually getting the vaccine and had enrolled in the study period when they were in that incubation period of time between symptom onset and when they initially received the virus. So the other question was about safety profile. And so the outcome was that the safety profile of the Pfizer vaccine was characterized mostly by short-term mild to moderate pain in the injection site, fatigue, and headache. The incidence of severe adverse events was low and was similar in the vaccine and placebo group, meaning that there was such a mild side effect profile that even individuals who had salt water put in their arms said that they had adverse effects. So again, how do we know the vaccine is safe? The CDC's advisory committee on immunization practices looks at the data. They give advice to the U.S. Food and Drug Administration, or the FDA. They then look at the data and advice from the advisory committee and decide whether or not to approve the vaccine. It took a while for these particular vaccines to get approved, for Pfizer to get approved, because they wanted more data, and they wanted to make sure that reviewers knew it was safe. It was allowed to be used for emergency use based on that initial data from that study, because it had such great results that they thought there's no way that giving folks this vaccine could be any worse than what we're seeing with individuals that are actually contracting the disease. So what are some limitations and remaining questions? These were questions and limitations after this December 2020 study. It was, what is the safety and efficacy beyond 2 months, and includes not included in this trial? Children, pregnant women, immunocompromised individuals. Since this trial, more trials have come out that have shown kind of the longitudinal data as far as, at least 6 to 8 months. There's been efficacy. There have been more studies with children. There have been individuals that initially said that they were not pregnant in order to receive the vaccine that were indeed pregnant, and they have been reporting whether or not they've had issues, which led to them actually doing studies with pregnant women. And there have been a number of immunocompromised individuals that opted to get the vaccine as well. So we have a little bit more information. Whether the vaccine protects against asymptomatic infection and transmission to unvaccinated persons, and how to deal with those who missed the second vaccine dose were some of the limitations of these studies. So again, all studies are going to have limitations and going to have more questions, which, as we can see from the data that's out there now, a lot of these questions have been answered. So is the vaccine safe during childbearing years? So the governing body for obstetrics and gynecology is ACOG, and they recommend that the COVID vaccine for all pregnant and breastfeeding moms. And this is why, because there are better maternal and neonatal outcomes. So the idea of susceptibility versus severity, there was no increase in susceptibility of pregnant women to COVID. However, they found that the severity of COVID was much more severe in pregnant women. The clinical manifestations of COVID are generally similar to those in non-pregnant individuals. However, you just have to think about a lot of the treatments and things that we would give to a non-pregnant individual, oftentimes a pregnant woman can't have. And so some of the treatments were a little bit different. The physiology of the body is obviously very different in a pregnant woman. And so that's why they were seeing more severe cases of COVID. A lot of pregnant women were needing to be intubated, which again puts the fetus and the baby at risk of different adverse outcomes from the mom contracting the virus. Other pregnancy-related complications were respiratory, cardiac, the thromboembolic clotting that we talked about, and skin, and then just psychological, just being pregnant during, a time when there's this pandemic going on. We found that there's no need to separate moms and babies if the mom has COVID, that simply masking, breast and hand hygiene were shown to prevent transmission. A lot of hospitals initially were separating babies from moms, and we realized that that wasn't necessary. They did some studies that showed that if mom wore a mask and just washed her hands and washed her breast, that there was no transmission to baby. And then they were shown that maternal COVID-19 antibodies induced by the maternal vaccination pass into the breast milk and may have protective effects for the infant. So one of the big myths was that COVID-19 vaccine can affect women's fertility. And so the fact is that it will not affect fertility. COVID-19 is not a live virus. The vaccine encourages your body to create copies of the little spike protein that we see everywhere on all the images of coronavirus. It teaches our body system how to fight it. It gives it, again, that cheat code to be able to say, this looks familiar. I've already made antibodies against this. Let me go ahead and destroy the actual virus when we encounter it. Checkology was something that I found when I was doing some research before and trying to help individuals figure out like what is true, what is fact, what is not. And it's initially made for teachers and educators and people that are kind of teaching learners how to differentiate between kind of real news and fake news. And so it's free. You can kind of go on there and take a little bit of a gander and see what you think. It seems to be a nice source for differentiating between different articles and things we find oftentimes on social media. It kind of gives a little bit of background about kind of where that information is coming from, and allows you to kind of use those detective skills in determining whether or not this is good information or not. So more questions. Who can help me make decisions about getting the vaccine? Obviously, your health and deciding whether or not you want to get it, you don't have to take my word for it. You have doctors and other people in the community that can help you with shared decision making. Shared decision making is basically people providing you information, you looking at your life and your lifestyle and coming together to figure out what would be the best treatment course for you. And I think that's important, you know, if there are concerns or questions, to make sure that you ask a trusted professional. What about kids? They've approved it for kids now. Is it safe? It is. Again, more studies have come out now that's showing that, again, when you compare the risk of these kiddos actually getting COVID vaccine and the protection are getting COVID virus versus them getting the vaccine, that the vaccine is such a more safe route. Everyone 5 and up is eligible to get the Pfizer vaccine. They had about 3,000 kiddos, and they determined that it was safe and effective with them. Pfizer is authorized for people 5 and older and has full approval for 16 and up. Moderna and Johnson & Johnson are authorized for ages 18 and up. So when we talk about safety and the ways kind of that the system protects against kind of things that should not be out and available to the public, we talked about Johnson & Johnson vaccine. So on the 13th of April, the FDA paused the vaccine because 6 people developed a blood clot soon after getting the vaccine. They studied the data about the blood clots, trying to see who was most at risk for getting them, why they might have gotten them. And then 10 days later, they decided, with the help of the FDA and the CDC, that it was safe again to start using the J&J vaccine because, again, the benefits outweighed the very small risk. What were the confounding factors in those 6 people that developed them? That they have some type of underlying reason why they got those clots? Was it something about the way their body responded to the vaccine that most other people didn't? What was it? And is that effect going to cause, you know, happen in the rest of the population, or is it just a subset of people? So again, it's important to report any serious side effects that you get from these, because it helps collect the data and it helps us continually monitor the safety of these drugs. And that's with anything. So what are the side effects? So you can get side effects from vaccines. They are very rare. It's possible to get pain at the injection site has been like the most common that we've seen in the ED, as well as fatigue and kind of flu-like symptoms. These typically last for 24 to 48 hours. Usually people will take a little Tylenol, rest, and then they go away. I've not seen anyone since I started residency admitted to the hospital for any life-threatening side effects of the disease here. So again, the immunity. So you have natural immunity versus vaccine immunity. And the CDC did a study and it said that those that were unvaccinated and got infected were 2.34 times more likely to get COVID again compared to fully vaccinated people. So they have a 2-fold chance of getting it. One study of people who had COVID indicated more than a third did not develop antibodies to the virus. And then we still don't know how long the response lasts and how long the immunity from natural infection is going to last. With the vaccine, however, has more effective and long-lasting immunity, standardized, predictable. Some reports indicate that individuals had lingering symptoms from their COVID infection versus after the vaccine. A little bit more myth busting. So the COVID-19 vaccine is unsafe. It was developed too quickly and was not thoroughly tested. And in fact, they have been proven to be safe and effective. No steps were skipped, and they went through the same process as other vaccines. We had another like SARS outbreak, and they had developed a lot of what they learned about that virus to help us with the development of this vaccine. And so this is an ongoing dynamic process of just developing these vaccines and using previous information to kind of help us with the current science that we have now. Myth: already had COVID-19, I'm protected against it. The fact is that you still will benefit from getting vaccinated since reinfection is possible, and we don't know how long you're protected during natural infection. These are the ingredients in the 3 different vaccines. And again, you have your active ingredient, which is that spike protein that is helping your body come up with the antibodies to fight. You have lipids or fats that helps it get into the bloodstream and into the body systemically, salts and other forms of the ingredients of the vaccine, which help to stabilize all of those molecules and keep the vaccine safe. And as long as you don't have an allergy to any of these specific ingredients, there is no contraindication to getting it. What's not in the vaccine? There are no fetal cells, blood products, virus cells, mercury, egg, latex, pork, preservatives, or microchips in the vaccine. I think the confusion about microchips was that on the outside of the syringe, we scan a lot of stuff in the medical field because it's one of the biggest businesses in the world. And often they have chips on the outside that they scan to keep for digital records, but you cannot fit a microchip in a syringe. It would not, it just simply would not fit. And so talking about the pandemic within the pandemic, there are a lot of excellent articles about how this affected you all's population, you know, the individuals that you serve. And some of the big points that I learned was that the stay-at-home orders that were used to protect the public left many victims trapped with their abusers. And then mandated reporters, such as teachers, childcare professionals, clinicians, have fewer interactions with these individuals to be able to recognize the abuse. And so for that, governing bodies need to consider social determinants of health when developing crisis standards of care. We have to do a better job as a system providing access to resources and other ways in case something like this happens again, because I don't think we were well equipped to deal with this population. Another article talked about perspectives on the provision of safe, equitable, trauma-informed care for these individuals during the pandemic. And things I learned from a system level, the pandemic led to widespread uncertainty, strained resources, amplified inequities, and loss of community. On the individual level, there were restrictions limiting survivors' ability to access these resources and be safe. And then even after the pandemic, the creativity, cooperation, and coordination that you all use to overcome these challenges are going to continue to remain essential to care and to give safe, equitable, and trauma-informed care. And this was nice, kind of breakdown of basically what I just stated. So we have the pandemic that exacerbated external stressors, restricted access to healthcare, fewer opportunities to leave abusive environments. There was fear of the infection. And then we had these community and system impacts that amplified the inequities within our system. We had these individual impacts where you have COVID as trauma compounding on top of other mental health strain, complications of childcare, working from home, learning from home. And from that, we came up with different adaptations, virtual interactions, flexibility of encounters and remote work. We still had some difficulty building relationships virtually. There were privacy concerns. We learned the importance of hybrid care, the emphasis on survival and emotional support. We started to refocus on people's basic needs. We got creative, collaborated, and coordinated, and all of this helped us create more safe, equitable care for these individuals. So a little bit more about me. So I was in my 3rd year of medical school when the pandemic started. I was also pregnant in the pandemic. And so for me, I had very similar questions to those not in the medical field. I wondered, you know, what this virus would mean, you know, for my family, what it would mean for me, what it would mean for my baby, and my patients. And so from this experience, I relied on science and on the evidence to kind of dictate the decisions that I made, and whether or not to get vaccinated, whether or not, you know, to go on trips and different things like that, because there's a new normal. Most of kind of my experience that kind of led me to the different decisions was when I was in the ICU, and what I saw in the ICU was just very sick people from not being vaccinated from COVID. And I only say that because all of the individuals that were severely ill in the ICU had not been vaccinated. Many of them had no underlying medical conditions previously. They were not on any medications prior to this infection. They were healthy, living their lives and with their families. And then they got this virus, and their body just responded so aggressively that it landed some of them in the morgue. And for me, that was frightening. And again, in juxtaposition with that in the ED, and kind of seeing people that came in, you know, after getting vaccinations, very less severe. No one was getting hospitalized. No one was needing breathing tubes. And so that small subset of the study that I have from just my experience kind of led me to do further research to see kind of on a population level where other people having and seeing those same things, and it was amplified. And that, you know, in those communities that were socially distancing and isolating themselves and wearing masks and getting vaccinated, the numbers were decreasing and the mortality was decreasing. And so for me, I opted, by the time the vaccine was developed, my child had already been born. And the question was, is it safe to get vaccinated during breastfeeding? And at that time, ACOG had not put out the statement saying that they thought it was recommended. They just were like, talk to your provider. And so for me, I couldn't think of anything worse than contracting this virus with a newborn baby and potentially giving it to him. And there was nothing that I saw from the side effects of, you know, the vaccine that were that as severe as me possibly getting the virus. So that's my experience. In closing, just my personal recommendation: get vaccinated, wear a mask when you're around others that you're not sure of what their vaccination status is. Stay 6 feet away from others, avoiding crowds if you can. Wash your hands often. And remember that we're a community. Our decisions not only impact us when we choose to do or to not do something, they impact the most vulnerable of us. They impact the children, the elderly, the immunocompromised, those that just don't have the ability to kind of mitigate this virus. And so you guys are doing great. Thank you for all that you do for the community. And thank you for allowing me to talk to you today.